Let's go to Argentina.
South America. Argentina. Córdoba. One of the most beautiful cultural and educational cities in the south of the world. Epicenter of the first university of the country, one of the oldest in the Americas. Knowledge, scientific progress, medical sciences, supported by last-generation technology, deeply committed to society and science. Right there, in an emblematic institution in the heart of the nation. A team of professionals with solid experience and outstanding expertise. A human group committed to the best care for children with congenital heart disease. Research, medical sciences. Argentina, south of the world. Hospital Privado Universitario de Córdoba. Since 1947. Ethics, knowledge, innovation.
Hi guys.
Welcome.
back. Great. We are ready to do the second live case, but as we agree with Fiat, we will take 10 minutes from the live transmission to show you case number 3 for Córdoba in the syllabus. So we can show more devices, more cases in this slot time. So case number 3 for Córdoba, please. This case was in the list of PICS, and due to we do just two live cases, we did this case on Friday. Adolfo?
Well, as said Alejandro, this is our today's third case, and it is about a 25-year-old single mother of 2 healthy boys who works as a waitress and who had a history of recurrent upper respiratory tract infection, and she has been referred recently for evaluation of a heart murmur and easy fatigue. She's 67 kilograms. She has a grade 3/6 continuous murmur at best heart at the left upper sternal border in the infraclavicular area. And she also has mildly bounding peripheral pulses. Her lungs are clear. She hasn't hepatomegaly. About her past medical history, she only has 2 C-sections without complication, and she is not on medication. About her pertinent test that was already done, the EKG is in sinus rhythm with heart rate of 61 per minute. The PR interval is very short, 80 milliseconds. The chest X-ray shows mild cardiac enlargement with mildly increased pulmonary vascular markings, and the TTE shows moderate to large size PDA with a minimal lamen diameter of about 40 millimeters, and left atrium and left ventricle are enlarged, and the pulmonary pressure is normal.
Next.
This is the chest X-ray. Next, the EKG with the PR interval short. Next, please. The 2D TE showing the enlargement of the left chamber and the ductus at the right position. And the next, please. Our intended intervention is a potential PDA balloon sizing and a percutaneous PDA closure using either the PFM nitoclude coil or the PDI R device.
Next. So on Friday we did this case. We did the hemodynamic. The SV sat is 73, increase in the pH up to 85. You see there the pressures, mean pressure of pulmonary artery is 15, everything is normal. QP is 7.3, QS 4.2, QPQS 1.73 to 1. The PVR is 2.05 wood units per meter square, and the RPRS 0.16. So all the numbers looks okay. Has a large duct in a 25-year-old woman who had 2 C-section, but this her congenital heart disease just was not discovered. So on Friday with this angio, please, the first angiogram, you see this is a left anterior oblique projection is 90 degrees. You see there the aorta, the ascending aorta is normal, is left arch with normal arch head and neck vessels, and you see there a type A PDA, Krichenko's classification, where the ductus is empty into the pulmonary arteries, and you see this is a nice PDA with contrast in the main pulmonary artery. In these cases, I actually was hoping that when we have adults with congenital heart disease, that we have a big clinic here. Most of the time it's very difficult to see the doctor, so sometimes we do balloon sizing of the PDA. Next, please. But in this case, that is nicely portrayed, we thought that was not necessary to do balloon sizing of the PDA. So you see there the right anterior oblique view, 45 degrees. We always do the PDAs in these 2 projections, and after that we take some measurements. Next for the measurement, please. So the aortic ampulla there measured 9.85, and the distal part of the PDA into the MPA is approximately 2.02. So we have many devices and many coils here to close this type of PDAs, and take into consideration that here in this part of the world, cost is an issue. So we every day we have to balance the best quality of care of the patient, but also taking having in mind that the cost is also an issue for us. So I would like to know the panel's opinion if they would close this PDA with a device, with a coil, and then we will show briefly what we have done.
I'm just going to speak quickly. I think that size and that shape, you could probably use any device and it would probably close the PDA. I'm not sure there's a preferable one over the other. So why don't we move ahead and just show us what you decided to do in this situation.
Okay. This is because cost is an issue, and in adult patient also we can use, or we can implant coils there. So we moved forward and we implanted a PFM coil. Due to the ampulla was 9.85 millimeters, we use an 11 times 6 millimeters PFM coil. Next, please. So there you see, next. So there you see how we cross in an anterior fashion the ductus, as all of you do. This is a standard of care here. Next one, and then the sheath is down into the aorta, and now we start to exteriorize the 11 times 6 PDA coil. You see that we open this distally into the aorta, so we like to see the coil confirmed properly in the descending aorta before approaching the duct. So now the coil is completely conformed there. You see that it's free there. Yeah. Next one. So next one, you see how the coil is there. The coil is coming, and you see how just not too much tension because the coil is going to pass through the PDA. So just gently you retrieve the sheath or the PFA sheath, and you see how the coil nicely adapts to that PDA's anatomy. Next one. So once you are there, you see that just has the PA loop inside the MPA, and you just push and see how it reconforms into the MPA going to the left pulmonary artery. Next one, and then you are happy there. Just take a quick angio to see the well-positioned coil there. Next one. So you see there how the coil fits nicely in the ampulla, and the last loop, the PA loop, is well conformed. Next one, you see how it releases now into and the wire goes into the left pulmonary artery. Perfect. And then next one, that is enough to hold the PDA coil, and this is the final angiogram, right anterior oblique. Next one, there you see how it's. So this is the purpose of this is to be didactic and to see that in all people, or older people and adults with congenital heart disease, we here can deal with them, trying to balance quality of care and also cost. So, any question for this case?
Yeah, we had a couple of questions from the audience. Go ahead, Garrett.
Yeah.
So through the electronic moderator system, there's a question from the audience about balloon sizing PDAs. So maybe we could ask the audience, does anybody routinely balloon size a PDA, or what circumstances would anybody balloon size a PDA? There's an awful lot of head shaking going on.
So when do you balloon size a PDA? We have a speaker, Jack.
Okay. So it's a question for me.
The main indication is pulmonary hypertension, isn't it? And but in adult patients, even without pulmonary hypertension, there may be some moderate-sized PDAs where it's very difficult to get an idea of the size and the profile of the PDA, and there you would do a balloon interrogation and an angiogram in order to get a more accurate idea of the size. But main one is pulmonary hypertension.
And for both those, you use a highly compliant balloon? Yeah. I think it's time we can move on to your next case.